I'll be with you in a second. I'm just setting up the YouTube, okay? We got 12 minutes. I'll be with you in a second. I'm just setting up the YouTube, okay? Farhan, good morning.
Hi, good morning. How are you doing?
Well, I'm using my backup system,
Yeah.
and I'm a little unsteady
Yeah.
because I'm used to my desktop, but the Windows went. I've got to get and working on my laptop now. You
Okay.
work on your laptop, right? You're using.
Yeah, for these I do laptop. One of the talks that I did was on desktop, the first one. But yeah.
Yeah. Well, you just get comfortable, but
Yeah.
I'll adapt. I'll adapt. So
Good
let's see.
morning.
Oh, well, there you go. Okay. Good day. Good day, Bezar.
Yes.
How you doing?
Good, great, thank you.
You both of you guys you're wearing a coat, but Farhan's not.
Yeah. I got
Yes,
the room warmed up. It's not very cold actually outside. Probably maybe 48. So still cold for you.
That's freezing for me. I start to freeze when it gets under 70. My body's changed, man. It's different.
Yeah.
I'm going up to Boston next week to a big college thing, and it's cold up there in Boston. It's
Yeah.
like Missouri, probably worse than Missouri.
Yeah. Actually, it is cold on the East
Yeah,
Coast.
it's cold, definitely cold country. But okay, Bezar, you've done webcasts before, right?
uh, not like that, but
Okay,
I know.
you want to run through anything?
Oh yeah, why don't you share your
Video
slides so we can make sure that your slides are working and videos are
Yeah,
working?
sure. These are my slides. Can
Okay.
you see?
Yes.
Yeah.
And uh, these are my slides. And how can I?
Uh,
Okay,
go,
play,
go to one of the videos.
Yeah, there you go. You got it.
continue to share.
Yep.
Yeah. Just like, yeah, I'll introduce you first. We haven't started yet. But take your
The,
time. Take your time. We got time.
so this it's working on my side. Can you see?
Yeah,
Yes.
yeah, we can see it.
Okay. And this one also working in on my side. So it's working, guys. I think.
Yeah.
Okay, very good. Okay,
Right.
why don't we get off the screen, Bezar? People will come in. Most people are watching this on YouTube, but okay, we're going to start now. And can you get off the screen share so I can introduce you?
Yeah, sure.
And Farhan, I'm going to introduce Farhan first, and then he's going to introduce you. Okay. So just get off the webcast, the presentation mode,
Uh,
or I can boot you off.
Stop share. Okay.
There we go. Okay, here we go. This will be the video that is recorded. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good day. This is Dr. John Bennett from the beauty of Miami Beach. So it's warming up. We have the pleasure of having the series of Farhan Siddiq, MD. He's a neurosurgeon from University of Missouri, director of residency training, and he invited a friend of his, Besar Atalay, MD from University of Missouri also, and I'll let Farhan give the proper neurosurgical introduction. Good day, Farhan.
Hi, thank you, John. Thank you, and welcome everybody for another episode of our case studies, neurosurgery and cerebrovascular case studies. Um, I'm really happy that we're expanding our portfolio and scope. Today, spine is our focus compared to some of the previous talks that we did. And I wanted to introduce to you Dr. Bashar Adle. He is originally from Turkey. He is a double doctor because he is an MD, PhD, and he did his initial training in Turkey with some of the esteemed neurosurgeons such as Dr. Yashar and Dr. Toure, and he was in practice with them for quite some time. Then eventually moved to United States and did more training and education at University of Miami, and then followed by University of at Yale University. And then he joined our faculty short while ago, and he's been a very phenomenal, productive, and member of our educational community. Loves to educate the newer or younger generation and specializes in minimally invasive spine operations along with other spine surgeries, complex spine surgeries. So having said that, I'll hand it over to Dr. Adelaide to give his presentation or talk. This is about technique for endoscopic spine surgery and basics of endoscopic, and then he will take on to some more complex later on as well.
Thank you so much. And also I appreciate for this opportunity to share my experience. I'm I'm a microscopic surgeon, but now I'm also an endoscopic surgeon because as far as I learned endoscopy, it opened new gates for me, I think, and I got a huge learning opportunities here. Also, we have a chance to work in cadavers here in Missouri. So I'm trying now to educate the residents for this. Let me share my presentation.
Perfect. Okay, it's perfect.
Okay. All right. Can you see?
Yes,
No?
perfect.
Okay.
Yes, we can see.
All right. Thank you. I want to cite two great surgeons. One is Walter Dandy. Walter Dandy is the first who published intervertebral disc, and I cited him because he's also from University of Missouri that we are working. And I also want to cite Professor Yashar because Professor Yashar minimal invasive microscopic discectomy I put his slides that he gave to me several years ago, and I had a chance to work with him like approximately 10 years. And at least he passed away last year, and I had some idea about the philosophy of minimal invasive surgery. So this is also Walter Dandy, and the other slide is the University of Missouri that we are working in 1839. So I started endoscopy more than 10 years ago. And then in this video, as you can see, we were doing it with tubes, over the tubes, under like very similar to how we do the microscopic discectomy. But as you can see on the lower part, the full endoscopic percutaneous technique is totally under irrigation, and it looks much more elegant, and you see much more because you can put your eye into the surgical area in this, as you can see. So I put this slide in order to compare that where we were and now where we are now. So I want to start with a couple of cases. This one is a 57-year-old male who came to me with some weakness. And as you can see, he has a huge disc at the L4, L5 level. And this is a right-sided endoscopic approach. And as you can see here, in the right side and L5S1 level, it also looks like some disc, but there's nothing. So I focused on L4, L5. So this is my video. So after introducing the needles and putting the tube, you have to orient yourself here. So this is the right side of the patient. So the superior on your right is the superior, and on your left is the caudal part. And then the front is the medial part. This was a very calcified disc. And then as soon as I entered the area, I'm able to remove the calcified disc. And the region on the left side is the superior articular process. And on the right side, the tube is protecting the nerve in this video, as you can see. So I'm working mostly on the disc, and most of the time, you know where you don't enter into the canal, but you know where the disc and where the nerve stands. So this is another one. You can see the left-sided now disc on this. And then this is again the video. Now this is the opposite, the left side, L4, L5. Now everything is opposite. Now the left side is this exiting nerve, and in the medial part you can see the traversing nerve. And now I'm completely on the disc, and the caudal part on the right side is the superior articular process. I will show you a couple of slides like that, and then I will go into details. So this is pre-op, and then this is post-op. You can see that this is the calcified disc. It's removed totally. So this is another one. And as you can see, this 45-year-old female with back pain and right leg pain. And it's a foraminal disc. It's a calcified disc with foraminal stenosis. As you can see here, and in the coronal views, you can see the foraminal obstruction on the left side. On the right side, sorry. So this is the video. And on the right side now, the right portion is the you should have the nerve in the right side, and the exiting nerve, and on the left side you have the superior articular process. So this is the place that I'm biting, is the region of the superior articular process. But when you go down more, and now coagulating the disc and the SAP portion, and drilling the SAP, superior articular process now. After drilling of the superior articular process, and now you can see the disc. You can see also the endoscopic cannula on the right, and it is over the exiting nerve root. You can use this approach in several different ways. You can approach to the midline, depending on your angle. But this is the most common way. This is not the usual way that we operate the patients with microscopic discectomy. So this has a special anatomy. So you have to learn the anatomy, because this is a little bit different that we know from our experience. I also do endoscopy in infection. For example, this patient is a L4, L5 discitis who was unable to walk. As you can see the infection here. And then now I will show you the video. In infection, I directly enter into the disc. So the aim in infection is to wash out the disc space and remove as much disc as possible. And you can also apply antibiotics into the area. Here you can see the different type of disc when you enter an infected area. So after washout, it clears away mostly. You can also send biopsy, culture. There is also another video after this, which is more demonstrative. You can see the disc material is very different than we usually see. So when I enter this area, I remove as much as possible and then coagulate and wash. And then this patient came back to me this week. By the way, all these videos are the videos that I did in the last 6 weeks. So you can see the infected materials. So yeah, after removal, cleaning, it's more, it's much better. And this is a failed back surgery patient with epidural abscess, as you can see here. We also recently did this patient. And the endoscopic discectomy is not the final surgery for these patients, but it really helps for shortening the antibiotic treatment and also makes the management antibiotics much more effective. So I approached like that to this area in that angle, so that when you give a more horizontal angle to your needle, so that you can even pass in front of the thecal sac, as you can see. And then when I entered and then drew the pus material, I entered my endoscope into the area, and now I will show. So first, I saw the disc here. So when I entered this disc, now this is a coagulation. After coagulating, I start to bite, and then you see the infected material inside. And remove as much as possible. This is not a usual disc, but like some fibrosis, some infected material. So you can also put some antibiotic integrated gel foams into the area. Also, when you clean it, the management is much more effective. And you don't have any incision in this cases, you don't even open. So now a couple of techniques. So I always put the endoscope in front of me and then the X-ray also should be just in front of you. And I generally put the patients on Wilson frame. And then the angle you can always measure with the CT scans, but there are several techniques that you can use for that. So marking the skin and then doing some angles, like putting your needle just on the lateral part of the superior articular process here, and then giving an angle depending on the location of the pathology. What I mean pathology is the disc. And then we enter through the Camben angle. And then don't forget that there may be different types of foramens, as you can see here. It may be shallow foramen, it may be a huge foramen. And as far as we know, that the anatomical knowledge on endoscopic discectomy is also getting much more detailed. As you can see here, there are ligaments over the nerve and inferior to and the lateral to the nerve. And then the most safe area is the superior articular process. And in this slide, also you can see the preparation. So first the AP, midline, disc space, and then doing the trajectory. I started these kind of skin markings while I was in Istanbul, and we were doing discography to the patients in like more than 10 years ago. So we started with discography. So as you can see in the slide, we can also measure the depth by lateral shots. And then needle positioning. So this is the safest needle positioning. The pedicule and SAP joining part, and then just inferior to the foramen is the safe place, and you shouldn't pass the pedicule in the anterior posterior x-rays. So I tried to put this picture. As you can see, this is the SAP, and then the junction between SAP and the pedicule is called the Wagner arch. So this is the safest area, and then it's away from the exiting nerve root, which is just above it. And also in this position, I tried to show that the needle positioning in the just medial to the pedicule and in the lateral. And when you apply this to the anatomy, it looks like something like that. Yeah, you are just over the Wagner's arch. There are, as I told you, there are some anatomical studies now accumulating. This is also one of the anatomical study which shows the more detail, the Cumbens triangle, with the showing the pedicules and the safe zone and the nerves exiting. So that's all my slides. So I can answer your questions if you want.
I thank you, Bashar. This was really great. Before I open up to the rest of the audience to ask more intelligent questions, I'm going to ask just a couple of questions. And I'm not an endoscopic surgeon. I don't do endoscopic spine surgeries, but I'm very fascinated with this new approach. So, question number one is, what is your contraindication for not being able to do endoscopic? Is it somebody who has a really collapsed disc and there's not enough space for landing zone, or do you think that almost every patient, even in the worst of collapsed far lateral discs, you are able to do this safely?
That's a great question. Thank you. There are different thoughts about that. So, lateral disc is a good disc to start, but the collapsed disc and the calcified discs, I think it's not good to start with. But as far as the endoscopy develops, now I think it may be the best way to start with most of the surgeries. We can start most of the surgeries with the endoscope, and if it doesn't work, then we can always continue with the other approaches. So now, for example, I started to do in infection and discitis, but it's like in discitis, it's not the final surgery. For example, the patient I showed, the first patient, I will do an ALIF and anterior posterior approach to that patient in a couple of weeks. But now I get some time and I have a better management option, and I have a good control of the infection, so that I have time to plan for a more definitive surgery for that patient. And also, I showed only the foraminal approach. I think it's great for thoracic discectomies. But at first, when I started, I definitely was thinking that it's a contraindication for the discectomy. I mean thoracic discectomy. But if you can give a good angle, so why not to try with an endoscopic approach? Because you don't do a thoracotomy, you don't do like you can directly go into the disc and make a decompression. Also, as I told you, I didn't show the other approaches because there is like endoscopic discectomy that the interlaminar approach, for example. And for interlaminar approach, we can do bilateral decompressions, unilateral hemilaminectomies, bilateral decompressions. We can do L5-S1 discectomy much better, but we can also do L5-S1 discectomy with transforaminal approach. So it's evolving, and then I think we will do much more cases. The only thing is that the learning curve is a little steep because it's a different anatomy, as I showed. So the getting adapted to this anatomy, I mean, is fundamental, very critical. So yeah, we just need to know which type of procedure to start with. I definitely don't suggest to start with calcified, very stenotic cases, because you may have incomplete decompression in that ones. But as you get experience, I think there are less contraindications for this surgery.
Thank you. Well, I'll open up the question answer session. I see a lot of people, folks have joined. Please feel free to raise your hand, and if you have any questions, introduce yourself so we know who you are. And welcome again, once again, to this educational case studies channel.
Yeah, I'd like to introduce Ronaldo Chacon. He's a neurointerventionist from Mexico, and I'm sure he has a comment or question. He's very active on social media. Good day, Ronaldo.
He has a guitar in the background too, which I like a lot.
Okay, let me get off the screen share.
Yeah, that's the discography that we did previously when we started this procedure.
There we go. Are you there, Ronaldo? You're muted, Ronaldo. You're muted. Está muto.
We can't hear you. Your mute is on.
Yeah, I'm telling him now. Está muto. It's better. No, he's experienced. He knows better.
Sorry. Okay.
There he goes.
Oh, sorry. Sorry.
Now we can hear.
Sorry for staying here late. I had some time problem with the time. Professor, what do you think about the Jacques Thiron technique? Jacques Thiron is a neurologist for French. He invented the disco gel. Disco gel is is used to reducing intradiscal pressure through dehydration of the nucleus pulpus, promoting retracting shrink rate of the hernia disc material, latest effect of nerve ingrowth and local tissue of the disc. What do you think about this technique, percutaneous technique, directly injection in the disc? I am neurologist, and I suppose you are neurosurgeon. And what do you think about this minimally technique? I know.
Yeah, do you mean the Destandau technique?
Yeah.
Okay.
Inject directly the alcohol or any stuff in the disc to provoke nucleolysis. What do you think really about this technique? Is technique by Dr. Theron in France.
Yeah, okay. So my experience I can tell you my experience about that because I have some experience with Dr. Destandao. I went to Dr. Destandao several years
Yeah.
ago. Actually, I started endoscopy after I saw his cases. Because it was very similar to our microscopic discectomy. And he
Yes.
was doing it in different several canals. The retractor was a little different. It was very practical, and I started to do my cases with the Estandard technique at first, like maybe 10, more than 10 years ago. But it's totally different technique than I showed today.
Yeah.
So I left that technique because then I learned in Germany from Dr. Thomas Lubers, the percutaneous full endoscope under full irrigation, full irrigation. So water dissection, you asked, I think it helps. It's neurolysis of the area, and then I think it really helps. That's one of the things that we don't do in normal open or microscopic surgery. So one of the advantages of this technique is that one. So it's under continuous irrigation because when it is under continuous irrigation, I think that's one of the reasons that there's very low risk of infection. And also, you can also treat some of these infections, with this continuous irrigation. So I think it's valuable. So you can also control the pressure, water pressure. I usually use like adjust it like to 30, the water pressure, and then when you increase, you can easily control the bleeding by increasing the water pressure also. So, but I'm still learning. Even I'm doing it several years, and I know different techniques. I did different techniques before, but I also have an experience and I have a chance to compare different techniques because, as I told you, I worked with Professor Yaşargil. He sent his patients to me. And when I was operating, he looked, he was observing how I do under microscope, the microscopic discectomy. So it was not easy for me to pass to the endoscopic because most of us have good results with microscopic discectomies. So most of us think that, so I already have more than 90% success rate. So why should I turn to another different technique? So I also had struggled with that, but now I'm very happy, and now I have another tool on my hands, and some patients it really helps. Let me give you
Right.
an example. For example, I was doing the far lateral discs by a Wiltse approach, opening from the lateral side, dissecting muscle with my finger, and then opening the intertransverse area. And then I was doing it like that. It was very good, but very successful. But I was doing it under my microscope. But by endoscope, it's much more simple. I mean, you directly can go into this area, and then it's shorter, and it's. By the way, it's not a good case to start with far lateral and discectomy. Uh, but it's really short and it gives the results are really good.
Okay, Professor, thank you so much. Another question. What do you think, Professor, Bob Professor, about the use of the AI in the new technique, for example, for patient selection and
Okay.
to try to avoid portal therapy compression steps and tricks and dose complication like dural leaks or nerve irritation? What do you think about the use of the new AI technology for the patient selection? Personally, what do you think about?
Okay.
about this new technology, the
Yeah,
use.
okay. So what I understand from question, please correct me if I'm wrong. Uh, I'm thinking about facet ablation, facet denervation, right?
Yeah,
So yeah, this is also a new area, new field for endoscopy. You can
yeah,
easily go over the transverse process and you can see with your eyes the medial branch block. So I'm really impressed with this surgery. So and I started to do that surgery because with the rhizotomy, I mean, it's a well-established technique. You can ablate, but you don't see the nerve. But in endoscopy, you see the nerve and you can ablate, you can cut it, and you can be 100% sure for patients.
yeah.
And it doesn't, I mean, very low, very quick operation, very low risk. So I really suggest people to start with this approach, the medial branch block ablation, medial branch block surgery. Yeah, it's a very new area. And then we also started to do that area. We
Oh,
started to do that surgery. I really like that, and it's low complication risk, highly efficient. You see the nerve, you cut the nerve, you can do ablation, you can do anything in that area.
Okay,
thank you so much.
Uday Bharti, a neurosurgeon from India. Hello, Uday, welcome. Go ahead and introduce
I'm
yourself
good, sir.
and
Thank
away
you.
you go.
Sir, I have a comment and a question. My comment is that your take on interlaminar surgery, I think it's very good point that we can do both contralateral and over-the-top decompressions, and we can release the contralateral nerve also. And that will be a good take that because it damages the multifidus muscle less. There's no incision also, and it's a kind of a motion preservation surgery. So I think it's a good take, and we can reduce unnecessary fusions from that technique. My question to you, sir, is this provocative discography. According to your experience over the years, is it beneficial or is destructive to the patient? Like, does it causes this damage over the years?
What, I couldn't understand the last part.
Pro- He's asking about provocative discography, whether it's dangerous to the patient in long run or is it beneficial?
Um, this uh, when I first started, I went to Germany, Stadtlohn, and then learned from Dr. Lubers. He was doing always discography, and then he was also introducing methylene blue into the disc. And then when you enter the disc under endoscope, you also see that this methylene blue, it guides you. It guides you. So several years, people did this discography. In philosophically thinking, uh, yes, it may harm the disc because it's a foreign material. Yes, I agree. There's no question about that. Now I'm not using it. I'm not doing discography at the moment. But I wanted to show my previous experience because I did also previously discography because it was an established technique in the past for uh, for both orthopedic surgeons and for also it was a routine technique in the past. No, we are not doing it anymore because now I think the reason we are not doing it anymore is that we have very good radiological techniques like MRI is very in the past there's no MRI. They have to do that, and
Thank you,
then
sir. Thank you.
yeah. Also, we
Yeah.
have more anatomical knowledge at today. We are still working on that.
All right. Well, thank you very much. If there are any more questions, please raise your hand. Otherwise, we'll stop today's session. Thank you, Bashar, for presenting. I really hope that you can present some other techniques also in future, interlaminar techniques, and make some other cool videos for differences in approach. I think that would be also very beneficial for our learners.
So,
Thank you
sorry,
so much.
Yeah,
sorry,
yeah,
Professor. So,
sure.
Dr. Basar, sorry. So do you think, do you through more in the discography than in the MRI for your surgery, surgery
Uh,
planning?
no, now I'm not using discography anymore. Not
And you
discography.
okay, all
I'm not
right,
using discography anymore. I use the MRI gives enough information, I think.
okay.
And
And
because we
simple,
can always we always do also CT scan, and a combination of this both are enough. But
and you
what I mean, we started to do it with discography, because when you do discography, you are more confident to enter this area, enter the disc, because it's the same place that we enter during at the start of the positioning of your needle that I showed in my pictures.
okay, brother. Thank you so much.
Yeah.
Thank you.
Okay,
Thank you.
thank very much, Dr. Ali. Very active discussion, which to me is the best education on the internet. And
Thank you.
Farhan, thank you for putting this together. And we look forward to having another webcast in 2 weeks. So once
Thank you.
again, thanks, Dr. Ali.
Thank you.
Thanks everyone for coming.
Thank you.
Thank
Bye.
you.
Okay,
Thank
you, Professor.
we're stopping the recording.